Welcome back to my History of Renal Medicine lecture series, in which we explore the colorful history of our understanding of one of the most important organs in the human body. My name is Matthew Tortora, and I practice diagnostic pathology in northern New Jersey, serving Cooperman-Barnabas Medical Center and Clara Moss Medical Center. This is the fourth installment of a multi-part lecture series on the history of renal medicine, which I've given before to the departments of pathology, medicine, and humanities at Cooperman-Barnabas Medical Center. This is part 2 of the second lecture entitled Sphygmographs, Lardaceous Livers, and Dropsical Effusions. A Far and Bright Journey from Richard Bright to Theodore Farr. We're going to pick up precisely where we left off at the end of the previous lecture. Let's get started. We last left off in 1827 with Richard Bright publishing his seminal work in Guy's Hospital, London, entitled Medical Cases Selected with a View of Illustrating the Symptoms and Cure of Diseases by a Reference to Morbid Anatomy. This work gave us the greatest understanding yet of the changes that take place in the kidney in disease states, and more importantly, it emphasized that by understanding the structure of the disease, we might come up with a cure. Bright would publish 2 other seminal works at Guy's Hospital in the years that followed, Goulstonian Lectures and Guy's Hospital Reports. It's worth appreciating that in Guy's Hospital Reports, he adds to his litany of intellectual accomplishments in our understanding of the kidney and disease. In it, he emphasizes the association of kidney disease with a laboratory abnormality, albumin in the urine. And he makes the first intellectual association of hypertension to microvascular abnormalities. In addition, he is the first to report a connection between renal failure and anemia, as depicted in this early illustration of a peripheral blood smear as seen through a microscope. Bright's contributions were not limited to the kidney. As was typical of intellectuals of the time, he was multifaceted, and he helped further our understanding of many conditions, such as diabetes, malaria, even Hodgkin's disease. Perhaps as extraordinary as Bright's work is what followed in its immediate wake. His early seminal works would lead to a frenzy of developments over the next 15 years, many of which were directly inspired by Bright's discoveries. Soon, doctors everywhere began testing urine for protein. An ensuing association between nephritis, uremia, hypoproteinemia, and lipoidemia was revealed. And there were discoveries of acute cases of kidney disease in which recovery may actually be possible. In 1837, Pierre Rare would link hematuria to acute nephritis, and he does so through the microscope. He might have even looked through an early microscope camera, like this, to capture an image, a photomicrograph, of red cells like this. Also in 1837, Gabriel Valentin would perfect a technique in cutting thin tissue slides for microscopy. This is the same general process used in modern pathology today. In doing so, he would stumble on an observation of a, quote, grayish substance in the tubules of kidneys. This would later be shown to be deposits of lipid-filled macrophages in the kidneys of patients with protein-spilling states, and this was dubbed lipoid nephrosis many years later by Munk in 1913. In 1838, an important assay, the iodide test for starch, was discovered, a blue color change being the positive indicator. More on this a little bit later. Around the same time, a scientist named Raspail was working to further improve the newly invented technique of cutting thin tissue slides by freezing the tissue before cutting it. He also made other contributions in areas such as cell biology. He was also a cultural icon of his own time. In fact, he was such a prominent figure in 19th century French society that later in his life, Van Gogh paid homage to him in his still life with a plate of onions, by including a magazine published by Raspail right on the cover, next to the plate. By 1840, the term nephritis enters use for pathologic classification for the first time. and although the broad category of illnesses still remained Bright's disease. And by 1842, our understanding of the structure of the kidney was taken to an even higher level. London in the 1840s. Now, you may remember from our last lecture that much of our backdrop takes place in London, and we are following its progress alongside that of our protagonist. Well, by the 1840s, London was sprawling well beyond its ancient limits, with a population now exceeding that of ancient Rome. And by 1842, London had just entered the Victorian era. A young Queen Victoria now sits on the throne. The new Parliament building is finished. Charles Dickens is writing his novels. London even has a railroad. And this physician enters our story. His name was William Bowman. And in 1842, 15 years after Bright showed us that kidney disease was associated with structural and diagnosable changes, Bowman was going to take our understanding of the microscopic structure of the kidney to the next level by exploiting the advances in microscopic slide techniques made possible over those prior 15 years. He was a surgeon, ophthalmologist, and histologist. In 1841, he was elected Fellow of the Royal Society for his work on striated muscle. In 1842, he would publish the structure and use of the Malpighian bodies of the kidney in the Philosophical Transactions of the Royal Society. In it, he published his microscopic observations on the filtration unit of the kidneys, the nephron, from various animals, including humans. Here's a close-up of an illustration of his illustration of that structure in humans. And for the first time in the history of our civilization, we could see how the nephron was put together. All the parts are there. The glomerulus surrounded by Bowman's capsule, the afferent and efferent arteries, the peritubular capillaries, and tubules, including the proximal, descending, ascending, and distal segments. It's all there. Here is it on microscopic slide in 2 dimensions. Here's a contemporary schematic, also in 2 dimensions. And here's a contemporary illustration in 3 dimensions. To summarize Bowman's work, Bowman showed us that there was a continuity between the glomerulus and the tubule. He gave a description of the components of the proximal part of the nephron, including the periglomerular capsule. He showed us the connection between the periglomerular capsule and the glomerulus to the proximal tubule, thus allowing the escape of filtrate produced by the glomerular capillary network. He described the filtration theory of urine function and the microcirculation of the kidney. He brought us from this to this. Thus, Malpighi's work was taken to a much higher level, taken, in fact, into the stratosphere. And he did it using the microscope. This is a Jones silver stain highlighting the glomerulus in a contemporary case of mine. May it immerse your mind's eye in the subtle beauty that lies under the microscope. To be fair, this is not intended to be just a lecture on science or microanatomy, but rather on history and why it matters. In today's world of instant results, 15 years between Bright's work and Bowman's work seems like a long time. But in the 1800s, it was faster than the speed of light. And when you consider that the span between Malpighi's work and Bright's work was 150 years, with almost nothing done in between, 15 years was nothing short of a miracle. The events of those 15 years were the perfect marriage of inspiration and ingenuity. Bright's work overturned the dogma of 1,000 years to reveal that changes in the kidney correlated to physical disease states. And because of this, one might also be able to treat kidney disease. The idea that understanding structure could lead to treatment was the inspiration for other scientists like Renal, for instance, to want to improve the technology, to observe these structures at greater and greater levels of detail. This, in turn, gave William Bowman the tools he needed to reach his next level of observation. It started a positive feedback loop. one which would turn faster and faster and faster from then on. But Bowman's legacy was not limited to the kidney, as evidenced by the eponemy in Bowman's membrane of the cornea and Bowman's glands of the olfactory apparatus. Let's move forward a little bit. In 1847, Dr. Henry Bence-Jones would discover that if you heated the urine of a certain patient who had a blood disorder such as myeloma, proteins would first precipitate out and then redissolve as you continued to heat it further. And as we reach the 1850s, it's worth briefly stopping to mention the life and works of one Dr. Samuel Wilkes. I've already mentioned the three great previously. This consisted of Thomas Hodgkin, Richard Bright, and Thomas Addison. But I left out their most important collaborator, Samuel Wilkes. A bit younger than them, he would work under and then with the three great, and his life and works would outlast theirs by a good length. He received early training at the Royal College of Surgeons. He was then trained at Guy's Hospital. He attained his MD in 1850, and he did many, many things. He was a demonstrator of morbid anatomy, a lecturer in pathology and medicine, the curator of Guy's Hospital Museum, an editor of Guy's Hospital Reports, and the president of the Royal College of Physicians. In the 1850s, he gave a series of historic lectures on anatomy. He was a true scientist, performing autopsies and emphasizing the importance of clinical pathologic correlations. He made many, many medical contributions. Since he outlived Bright and his colleagues by many years, his research furthered the scientific works of each of the three great. As part of this process, he even rediscovered and advanced the observations made by Hodgkin on generalized lymphadenopathy with enlarged spleen, years after Hodgkin's death, the name of which Wilkes deferentially called Hodgkin's disease. Equally as noteworthy, he actually wrote biographies of the three great, and in doing so, he curated and preserved their legacies, helping to carry it and the spirit of their work into the 20th century. By the way, in 1853, true to his mission, Wilkes furthered the works of Bright by demonstrating hardening of the arteries in patients with Bright's disease. Why is that important? Because by showing that arterial disease and kidney disease were related, it made some people more interested in detecting arterial disease. And in 1854, the sphygmograph was invented. Here's the original device, looking and functioning more like a seismograph. But over the next 50 years, it would see many improvements. By 1863, the portable sphygmograph was invented. By 1880, a sphygmograph was converted to a sphygmomanometer by using water and then air-filled balloons to compress the radial artery. By 1896, the balloons were modified into a cuff. Pictured here is a famous physician named Frederick Recklinhaus, whose work is associated with neurofibromatosis and hemochromatosis. But it was his son Henrik who improved the sphygmomanometer by widening the cuff. By 1901, famous American physician Harvey Cushing would travel to Europe. He would observe the sphygmomanometer being in use there, and he would further improve the device. Since he was an influential physician, when he returned home, he helped popularize its use in the United States. Finally, in 1905, a stethoscope was added to the routine, and the archetype of the modern sphygmomanometer was now in place. And why was all that important? Because right in the middle of its development and evolution, Frederick Mohammed used it to make the first connection between hypertension and arterial disease. By the second half of the 19th century, advances in pathologic diagnosis were starting to show the fruits of their labor in our understanding of kidney disease. In this regard, there are two pioneering medical discoveries worth mentioning. The first was something called scarlatina. Scarlatina, also known as scarlet fever, is today known to be caused by an immune response to Streptococcus bacterium, either during or after the infection subsides. When it occurs after the infection, It's called post-streptococcal. The effects of scarlet fever were linked to the kidney by William Howship Dickinson in as early as 1865 in his work, Diseases of the Kidney and Urinary Derangements. Most of these cases of acute nephritis were what would now be known as post-streptococcal glomerulonephritis. By 1885, Langhans describes a type of Bright's disease with glomerular inflammation. He describes the post-scarlatinal kidney changes as taking place in the glomeruli. And he does so using the microscope. And here's what that would have looked like. Here we can see an image of a glomerulus that has been severely imaged by the post-streptococcal immune response in a patient who had scarlet fever. The second discovery involves a waxy, clay-colored, lardaceous substance. In the 17th century, Bartholin, who you might remember from a few lectures ago, had come across the spleen of a patient which was so hard it could scarcely be cut with a knife. In the 18th century, Wainwright described strumulous swelling in the neck and clay-colored pituitary substance in the liver. And in the 19th century, Abercrombie described a liver with a uniform yellow color, resembling impure beeswax. This is the color of that pituitous, clay-like, waxy, lardaceous substance. And here it is in the liver. By the mid-19th century, the scientific observations had shifted away from this substance being of a lardaceous or fatty origin, and instead towards it being of a proteinaceous or protein origin. But it was preeminent pathologist Dr. Virchow who gave this substance its modern name, amyloid. This was based on the mistaken identification of the substance as a starch, amylum in Latin. Based on positive staining from that crude iodide technique mentioned a few minutes ago. He also happened to notice that the iodine test stained the glomeruli and the blood vessel walls of patients afflicted by this condition. Continuing to capture the zeitgeist of the post-Malpighi and post-Bright scientific mindset, Virchow noted that, quote, analysis of the whole organ was inadequate, and that only when we have discovered that the means of isolating the amyloid substance shall we be able to come to any definite conclusion with regard to its nature. Meanwhile, over at the Royal Society of London, there was a big debate ensuing about what to ultimately call this substance. Of course, in retrospect, we know that the winning name was lardaceous. It was Samuel Wilkes, then in charge of the Royal Society, who recorded that the committee recommended that the term lardaceous could be adopted by the Royal Society because it was widely used and well understood. But ultimately the term amyloidosis did prevail, perhaps due to Virchow's immense standing as a preeminent pathologist, and also to the common use of the iodine stain as a diagnostic test. The positive feedback loop of scientific advancement continued unabated through the second half of the 19th century, as evidenced by the technical advances in histology, that is, the study of the microscopic structures of the body. In the 1850s, aniline dyes were first discovered, and they included such colors as fuchsin, perhaps named after botanist Leon Fuchs, or perhaps named after the flower fuchsia, or both. There was indigo, which henceforth colored our genes. And there was also one named eosin, after the Greek god of dawn. Eosin, as it turns out, also stained the cytoplasm of cells bright pink when applied to tissue. By 1865, Franz Bohmer had published the use of alum hematoxylin as a nuclear stain, which colored the nuclei of cells purple. And thus was born the paired hematoxylin and eosin tissue stain, which is still used today as the routine histologic protocol for almost all tissue slides, H&E. If anyone is interested in knowing what this slide shows, which is stained with H&E, feel free to reach out to me and we'll talk about it. In addition, the concepts of fixing tissue in formaldehyde and then embedding tissue in paraffin were put forth at this time, leading to much greater processing efficiency and much greater slide quality. In terms of staining amyloid, there was some progress made by a man named Johann Meckel, who came from a very storied pedigree of Meckel scientists. But the real next level for amyloid staining came from a man named Friedrich Bayer. Bayer was the founder of Bayer AG Pharmaceutical and Chemical Company in Germany in 1863. His first product was acetylsalic acid, which we know today as aspirin. But perhaps his most famous product was this. He commercialized the use of heroin, even selling it over the counter for the use as a cough suppressant. It was considered a non-addictive substitute for morphine. So I guess we have a lot to thank Bayer for. Now a brief timeline. Paul Bottinger was a man who worked for Bayer, and in 1883, he was working on a bright red-colored aniline textile dye, pictured here. He then sold it to the AGFA company of Berlin. As it so happens, in 1884, the Berlin West Africa Conference took place, which was an important event in the colonization of Africa. Here's a photograph from it. This conference centered around issues with the Congo River Basin, and since the idea of the Congo seemed very exotic to Europeans at the time, and that bright aniline dye happened to be invented in that same time and place, people were eager to ascribe Congo to its name, which was a common practice at the time. The bright red dye and several other colors were given the prefix Congo. Soon they began to use Congo red to stain tissue, and as luck would have it, eventually it was discovered that it stained amyloid really well. It would even turn bright green under polarized light. London in the 1880s. The famous Tower Bridge is going up. London's revolutionary sewer system is beginning to attract guided tours. The dome of Christopher Wren's iconic St. Paul's Cathedral is now rising above a sea of antique shops and flats, all of which will be reduced to rubble in a war in the next century. But in the meantime, London is now a sprawling metropolis with an almost unimaginable population of 5.5 million souls. As for our understanding of kidney disease, there was much to be proud of by the close of the 19th century. We had witnessed the birth of nephrology, coined the term nephritis, demonstrated depictable morphologic correlations between the kidney and diseases. We had demonstrated a relationship between kidney disease and albuminuria, edema, hyperlipidemia, hematuria, anemia, high blood pressure, and we had landed upon the Bence-Jones protein. We had a microscopic understanding of the kidney, and then through the microscope had observed several renal-associated diseases, including post-scarlatina glomerulonephritis, renal amyloidosis, and arterionephrosclerosis. And contemporary etchings of scientists like this, looking at slides like this, with equipment like this, were emblematic of the fact that finally, by the turn of the century, the microscope begins to supplant gross observation in the evaluation of kidney diseases. By the year 1911, many of the most iconic figures of the 19th century, political, literary, artistic, and scientific, were dying away. One of which was our venerable friend, Samuel Wilkes. And as famed pathologist William Osler wrote, "With his death snaps the link between old medicine and the new, the link which united the profession with the famous clinicians of the early part of the last century, Bright, Addison, and Hodgkin." But all was not sad. By 1914, the next stride befitting of his legacy was about to be made, when Volhard and Farr published the very first textual classification of renal diseases, in 1914, Breutsche Nierenkrankheit. They classified renal disease into three major symptoms: degenerative, inflammatory, and chronic disease, and they did so by combining clinical findings with pathologic findings, which was the first treatise of its kind. It did have limits. For instance, they failed to recognize the glomerulus as the source of proteinuria, but it was a brilliant start to the 20th century. By this point, I think it's safe to say that the quote from H.A. Christian, "It is not possible to diagnose in life the anatomic changes that will be found in the kidney after death," would be proven wrong. But we are still only at the beginning, and there is still much to learn. Keep in mind that this ideological fallacy persisted into the 1920s. If you choose to join me for my next lecture, I will take you through the extraordinary work of the first half of the 20th century and lead you right up to the edge of the astonishing world we know of today as the modern era of renal medicine. Thank you again for joining me. Once again, if I've piqued your interest in the history of medicine or in pathology, if you'd like to know what that H&E stage slide I showed earlier represents, or if you'd like to see the works cited list for this lecture, please feel free to contact me or follow me on X at Renal Pathology.